All right, everybody, let's go ahead and get started. Welcome to the last MMI Grand Rounds of 2020. Today's Grand Rounds is extra special because we are welcoming Dr. Georgia McIntosh as the incoming Associate Chair of Quality and Safety for the Department of Medicine. As you all know, Dr. McIntosh is a very well-known and very well-respected member of the Department of Medicine faculty. She completed her graduate medical training at the Pennsylvania State University College of Medicine, and then went on to complete her internship and residency here at VCU. After that, she was a chief medical resident and then joined the faculty of what is now the academic hospitalist program, where she's currently an associate professor. Dr. McIntosh is a highly regarded educator. She earned her graduate certificate in medical education from the Teaching and Medical Education program here at VCU. She's been recognized multiple times for her dedication and talent as a clinician educator. To mention just a few of her awards, she's received the Outstanding Ward Attending Award from the Medicine House staff, the Dr. David Markham Award for Excellence in Teaching from the Department of Medicine, the Award for Excellence as a Clinical Educator from the Department of Medicine, and also the Leonard Tao Humanism in Medicine Award from the School of Medicine. And of course, Dr. McIntosh has dedicated herself to improving patient safety and quality throughout her career. She completed training in quality improvement from the Institute of Healthcare Improvement and also attended the Quality and Safety Educators Academy. She has served as the Associate Program Director for Quality for the Residency Program and currently is the Quality Director for the Internal Medicine House Staff Services. In these roles, she's made significant contributions to improving interprofessional collaboration, reducing harm from medication errors, addressing inpatient mortality, and much, much more. And I look forward to all the incredible work I know she's going to do when she assumes the role of Associate Chair in January 2021. So please join me in congratulating her. And today, Dr. McIntosh is joined by Dr. Melissa Chouinard, who has helped us out with MMI Grand Rounds before. She's obviously an academic hospitalist and also the physician chair of the Medication Safety Group at VCU. Taylor Pence, a third-year resident in our internal medicine program, and Adnan Khan, who's our chief resident in quality and safety, who I would also like to thank for just being an excellent partner this year. He represents the house staff at all of our meetings with the quality directors where we discuss safety intelligence reports, and he's been collaborating on projects with internal medicine house staff services, and I'm so grateful for his help. And so with that, I will hand over the virtual mic to Dr. McIntosh.
Thank you, Dr. Hartigan, for that really warm and that introduction. I've definitely got big shoes to fill, but eager to continue this work with all of these really smart folks. Can everybody hear me okay? All right, well, we're gonna get started. So as you all know, the goals of MMI are to really learn from medical errors or any complications, unanticipated outcomes that we might have had. Our goal is really to engage our faculty and our learners in looking at any critical incidents or near misses, and really to identify system errors and again, to improve upon those errors. Of course, we're not looking to identify any one person. That really our goal is to look at the system, and of course to have transparency regarding any organizational improvement efforts. With any grand rounds with MMI, our goal is really not to point fingers, but to use more open-ended thoughts. So if there are any questions, we like to use I wonder statements as opposed to they should have. With everything, we always are confidential, so we don't use any identifiers. And again, our goal is to uncover any fixes, any ways that we can improve care for our future patients. So the objectives of this conference today is really specifically to look at the challenges with performing accurate medication reconciliation. We're going to talk a little bit about what best practice elements are out there to improve medication reconciliation. And then we're going to describe some of the current quality improvement efforts that we're doing now in our residency program to improve that discharge med reconciliation. So with that being said, we'll spend a little bit of time on the case presentation and missed opportunities. We'll go into a little bit of background and barriers and best practice elements. We'll go into the data review and how we're doing here at VCU in internal medicine. And then we'll hear from our residency program specifically on how they are taking this data and moving towards a fix. And we have no disclosures for this conference. So our first case is Mrs. W, a 54-year-old woman, multiple medical problems, diabetes, hypertension, GERD, was actually admitted from sheltering arms for acute on chronic hypoxic respiratory failure. So Mrs. W had a very complex preceding hospital course. She had actually been admitted in the spring with COVID pneumonia and acute hypoxic respiratory failure. She was transferred to VCU after 4 days for high flow nasal cannula and actually remained inpatient for 65 days due to complications of COVID, fungal pneumonia, pneumothorax, and delirium. She was eventually transferred to Vibra for continued care at LTAC, but after 2 months of being at Vibra, was transferred to sheltering arms for inpatient rehab. After her short inpatient rehab stay for 14 days, she unfortunately developed acute on chronic hypoxic respiratory failure and required to be readmitted to VCU. After 4 days of being in the inpatient stay, a full med reconciliation was performed by a clinical pharmacist and was found to have multiple medication inconsistencies. Her apixaban that she was discharged on had actually been discontinued at the inpatient rehab facility and actually had a decreased dose due to a contraindication with another medication. Her atelvacone had been discontinued at the rehab facility, but was continued upon admission inadvertently. Her insulin was also discontinued at the rehab facility, but was continued. Quetiapine was continued here that had been discontinued. Lorazepam scheduled had been discontinued, but was continued here. And torsemide, again, had been discontinued and was continued here. And notably, I want to make sure that we highlight that 3 of those medications that were inadvertently continued were those high-risk medicines, apixaban, insulin, and a benzo. Because of those inadvertent commissions, the patient actually developed stage 3 AKI that persisted for a week, but eventually resolved with holding her diuretics. She was also monitored closely for developing hypoglycemia. This did not happen, but it did involve a number of increased blood sugar checks and nursing monitoring. Our second case is Mr. H, 73-year-old with heart disease, hypertension, HFpEF, was brought to the emergency room by his daughter with altered mental status. Patient's daughter called the patient at home who lives by himself, and the call was unanswered. So thus the daughter went to the house and brought him to the emergency room. Unfortunately, because of the patient's altered mentation on admission, a med reconciliation was not able to be completed. And so the admitting provider noted a previous hospital list that had multiple antihypertensives that was from 6 years ago. And so resumed those medications. Unfortunately, the patient became hypotensive, required numerous fluid boluses, and a change in level of care for more intense nursing monitoring. The daughter later confirmed the patient was not on these, the majority of these antihypertensive meds that were ordered. And so this brings about the challenge to performing an accurate medication reconciliation. So why is this so difficult? So some of the initial studies were done with the Institute of Medicine with their big expose about the unsafe practices that we have here in the United States. So back in 2006, they published the Preventing Medication Errors and noted that medication errors were responsible for 1.5 million adverse drug events annually, costing $3.5 billion. 40% of those errors are attributed to inadequate reconciliation at times of transitions of care, and up to 20% of these are considered harmful. AHRQ similarly describes 40 to 54% of patients that experience unintended medication discrepancies upon admission to acute care hospitals. And 40% of discrepancies occur specifically at the time of discharge. These discrepancies are numerous, but the most common is usually omissions. Almost up to 46 to 56% of the patients have something omitted by mistake. Commissions are the next frequent, so something that was purposely discontinued, but unfortunately got reinitiated are the next common. And then of course we have different dosing, different routes of administration, different frequency, or different medications within the same class. The challenge of performing an accurate medication reconciliation is grand in that there are so many components that go into why this is so challenging. As we know, if there is a process, but without an owner of that process really doesn't go smoothly. And so oftentimes there's no clear owner of who should be doing this. With that, there's variation in the process of doing this itself. There are multiple disciplines involved, pharmacists, nursing, as well as providers. And many healthcare providers are not trained on how to do this well. Patients, of course, may be unfamiliar with their medications. Providers may also be unfamiliar with certain new medications that look unfamiliar, and thus may be reluctant to order those unfamiliar medications. There also is a lack of integrated records across the healthcare continuum that just makes things more challenging. It's time consuming to do this well. Then again, more reasons. There's oftentimes a lot of data that gets put into a patient's chart, but a lack of comparison and resolution about those discrepancies. Information may be incomplete or out of date. There is often patient acuity that prevents this from being done well or timely, patient lack of knowledge, provider workflow, and oftentimes there's a lack of importance viewed from the provider, and it is viewed as more of a checkbox to complete rather than something that is important for safety. So all of these things contribute to why it is so difficult to do. Fernandez published a nice schematic in Pharmacy Practice back in 2009 that shows all of the different components that go into how this gets done or not done well. Patients come from home, you have to interview the patient specifically, look at their medication list, maybe look at a database of information for that specific patient to really hone in and glean a best possible medication history. But as we know, as patients go from different components of the healthcare system, all of these have an easy way for things to be altered or erroneously enter. I like this schematic because we have two big areas in terms of where mistakes can happen. As we know, if we have data that is not correct on the admission, even with a perfect model, the results are not going to be reliable. Similarly, if we have great admission data, but the process is flawed, the results are still going to be flawed. So both of these lead to a very challenging task to do. As further confirmation of how challenging this is, the Joint Commissions has actually changed its stance in terms of what should healthcare systems be graded in terms of the med reconciliation. So in 2005, the term medication reconciliation was actually coined by the Joint Commissions as a national patient safety goal and was used to actually give accreditation to healthcare systems. However, in 2009, the Joint Commissions recognized the difficulty of performing and assessing this really accurately for healthcare systems, and thus took that, the medication reconciliation piece away as a means of assessment for accreditation. In 2011, however, they recognized that it's still a significant piece of data and really helps to guide errors and patient safety. So reintroduced the concept of medication reconciliation in terms of national patient safety goals kind of spread throughout, but it's no longer used as a scoring tool to assess accreditation for institutions. So again, really just highlighting how challenging this work is. Some of the seminal work, I just want to highlight one of the most important and highly cited studies that was done back in 2009 by Chouinard and al. Looked at pharmacists counseling with regards to looking at adverse drug events. So this was a randomized study to look at pharmacists as they did intensive counseling and follow-up calls with patients as opposed to usual practice. 300 patients were initially assessed for eligibility, and 178 eventually got randomized to interventions with pharmacists versus 84 assigned to usual care. And with this work, on table 2, we see that pharmacists were actually able to catch multiple errors for patients. So at discharge for 45 patients, 91 of those patients, or 91 times, patients actually had discrepancies with their pre-admission medications as compared to their discharge medications. As you can see, that N is greater than the number of patients, and that's because many patients had multiple errors. And so those pharmacists actually were able to significantly reduce the events of preventable harms. The pharmacy intervention arm had 1 preventable adverse drug event, as opposed to the usual care arm that actually had 11 preventable adverse events. And with that, healthcare utilization was also significantly changed with the pharmacist arm as opposed to the usual care arm, with 1 preventable medication event in the patients that had extra healthcare utilization under the pharmacy arm as opposed to the usual care arm. So one of those initial studies that really showed how important and how impactful using pharmacists are with patients in the inpatient setting can be. I'm going to highlight another key study that was also done back in 2010 by Gleason and al. In JGIM that looked at the results of medications at transitions and handoff. So again, looking at those medication reconciliation errors and a predictive model to help identify those patients that would be at high risk for errors upon discharge. This study looked at pharmacists as they studied the prescriptions on admission, as well as the admission orders that were entered by inpatient providers. As they looked at the differences, they assessed differences between admission histories and prescriptions, as well as the differences between admission orders. If there was no clear description of why there is a difference, it was considered to be an error. If there was a description of why there was a change, that was not determined to be an error. And with this study, they actually were able to identify a number of risk factors in terms of who would be at higher risk for those errors. On the table 1, as we can see, a significant p-value for those patients that are 65 and older, both patients without errors and patients with errors had a significant p-value. When they did the logistic regression model, those patients that are 65 and older had an odds ratio of 1 or more. So again, age of greater than 65, patients that had limited English proficiency, any patient that had an ICU stay during their hospitalization, patients that had a high number of pre-admission prescriptions, a mean of 7 or more medications, as well as patients that had a change with their pre-admission prescription within the 1 month preceding that admission. So all of these were able to get high risk factors for patients that were going to be at risk for adverse events at the time of admission. And these are things that we know about: polypharmacy, higher age, patients with multiple providers, but also patients with developmental or cognitive impairment, patients that had some kind of dependency or vulnerability, patients with multiple high-risk medications, poor health literacy, and low English proficiency. I'm going to skip through this piece just to save on time a little bit. And I want to go towards the best practice for achieving a good and accurate medication history. So one of the things that we know is really impactful for the best possible medication history is more than just getting a list of medications from the patient. The first piece should be that routine medication history, but the second piece should really be a systematic process for interviewing the patient and the family, and then confirming that list with some other source of information. So either a central medication database, looking at actual medication vials, or calling the community pharmacy to obtain and verify medications. The Joint Commission outlines 5 different steps for completing this medication reconciliation. So initially, to develop that old list of old medications, developing a new list of medicines to be prescribed, and then comparing the 2 lists, making decisions about any changes that might need to be made, and then communicating that to the patient and the provider. The IHI also has 3 different steps, kind of the same thing: collecting that history, clarifying that the medications and doses are correct, and then reconciling those orders. I think both of these really just speak towards how intensive this work actually needs to be. The Society of Hospital Medicine has done a multi-center med reconciliation study that is started in 2011 through a grant through AHRQ to really help providers to get trained as well as to get best practice in terms of how this should be done well. And these best high performance behaviors are outlined here. As you can see, it's actually pretty intense, but really takes a lot of time, dedication, and training to really get a good sense of what patients are taking, as well as to confirm it with some other source. The Pharmacy Society of Wisconsin has also been well known in terms of doing this well. And we have adopted many of those strategies here using the discharge med reconciliation process, educating patients, making sure that we have a reliable way to get patients their medications when they are discharged, including meds to bed, having a pharmacy handoff communication to the outpatient pharmacy, and providing follow-up communication to the patient and to their healthcare team. And I'd like to just include those high-risk medications, because those are oftentimes those medications that our patients have trouble with and that can get them into real trouble when they get home. I want to leave with other techniques that healthcare systems have utilized in terms of really doing best practice. So we know about the sterile cockpit technique. We know that the admission and the discharge reconciliation process are really time-intensive tasks that really should be done without a lot of external devices or external input. So really to use that work and use that time as that sterile cockpit, really making sure that people are doing this without a lot of distractions. And then making sure to have attention towards the health literacy of the patient and including any information that is at a 5th grade or lower level for patients to understand. So I'm going to turn this over to Dr. Chouinard to speak a little bit about our data here at VCU, and then we'll go into the QI project that our house staff is doing.
Okay, so I do not plan to take up a whole lot of time because I'd like for us to focus on what our house staff have done, but I wanted to show each of you a little bit about our medication reconciliation data. Some of you may have seen this from the quality directors who have tried to disseminate some of this information. We've noticed over the past several months that some of our reconciliation numbers and our compliance has not been as good as in previous months. So one of the things that we've done with the Medication Safety Committee is taking a look at the medication reconciliation data that's available from the hospital and tried to come up with a good way to look at it over time. The institution sends out a monthly report that shows off the data that's broken down by service, also broken down by attending, and trying to look at that data in isolation over a month cannot be all that helpful, but looking at it over time and looking at it based on service gives us a little bit more information. So this is the overall departmental data over the past 13 months, including October of 2020. And you'll notice that our admission medication reconciliation goal is a little bit different than our discharge medication reconciliation goal. So the health system recognizes that sometimes patients who come in to the emergency department or as an outside hospital transfer or as a direct admission might not be able to provide the history that is needed to complete an accurate medication history. So the goal is within the first 48 hours of admission to have 95% of our patients have a medication reconciliation completed. Now, at the time of discharge, patients should be improved and we should have the ability to complete a discharge medication reconciliation to ensure that patients get the right medications at discharge and have a decreased risk of readmission. Now, for those of you who actively perform discharge medication reconciliations, you will know that Cerner has a hard stop in place where our discharge order is not allowed to be placed unless you've completed a discharge medication reconciliation. And because of that, our discharge medication reconciliation goal is 99%. So if you'd like to take a look, obviously, July, August, and September of 2020 were our most difficult times. We are starting to see a slight improvement as of October 2020. And hopefully with some of our efforts at increasing the awareness of the importance of medication reconciliation, but also that these numbers are available and out there so that you can follow your own performance over time. Hopefully that will improve some of our numbers. So next up, I want to highlight, just like Dr. McIntosh did, the importance of our pharmacists and how amazing they are. They have become a great resource for us within the Department of Internal Medicine, both the clinical pharmacists and the medication history pharmacy team. The medication history pharmacy team has recently undergone an expansion. We've hired several new pharmacists to assist with obtaining an accurate admission medication history so that we can try to avoid that garbage in, garbage out model that Dr. McIntosh mentioned earlier. So it's staffed by pharmacists and pharmacy technicians. They can be paged at a virtual pager number that is covered. It's pager number 9240. So if anyone wants to write that down and keep in their back pocket as a resource, they're very happy to help us on those patients who are very complicated, or if you're having issues with trying to contact the right pharmacy, they are very happy to help. With the increased staffing that they have, they are working to improve the coverage schedule. So trying to get more evening and weekend coverage. So the goal is to then have 7-day-a-week coverage late into the evenings. And one of the things that we'd also like to focus on, not just our admission medication reconciliation, but also our discharge medication reconciliation. Recognizing that if we can get a great admission medication history, then it will make it a lot easier for us to do an accurate and safe discharge medication reconciliation. So we'd really like to have more pharmacy involvement in our discharge counseling. So hospital medicine performed a Lean Kaizen event earlier in the year, where a clinical pharmacist assisted with the discharge medication reconciliation. Now, that could be sitting down with the team or reviewing the discharge medication reconciliation after it was performed. The pharmacists caught multiple errors and were able to prevent discharge medication reconciliation errors, and overall improved the satisfaction of many of our hospitalists, who were quite grateful to have that extra resource and that extra double check on discharge. So one of the things that Dr. McIntosh mentioned earlier in her presentation was the resources that are out there provided by the Society of Hospital Medicine. And one of those resources is a return on investment calculator. So this ROI calculator has two components. One of the components that I'm going to focus on here is using pharmacists to assist with our discharge medication reconciliation and also counseling for high-risk patients. So I'm going to show you that ROI calculator on the next slide, but I wanted to show you that there's really only two or three things that you need to put into that calculator. So the first one is, how many patients do you admit to your health system? The next is, how many of those patients are high risk? So the initial assumption in this ROI calculator is that 25% of patients are high risk. Now, we can go back and adjust that number if needed. If we say, oh, I think maybe more than 25% of our patients are high risk because we have a higher rate of health illiteracy, or we have a higher rate of patients with multiple medications. And then the calculator then assumes that a proportion of 30-day readmissions to our healthcare system are preventable with pharmacist intervention. And so it then outputs the number of FTEs required for pharmacists to then perform the discharge counseling and assist with discharge medication reconciliation. It then also has the added benefit of showing the estimate of the savings to the hospital that would be provided by preventing those adverse drug events and readmissions. So this is the calculator. You'll notice that up at the top, I've input the fiscal year 2020 numbers for the number of inpatient admissions. So this is the number of inpatient and OBS admissions to VCU. And you'll notice that I use the 25% based on the marquee numbers that were provided. I input the pharmacist salary and the pharmacist fringe benefit rate, and then the calculator did the rest. So you'll notice the annual savings to the hospital as a result of avoided harmful medication errors is about $1.75 million, which is a hefty number. And then you'll notice at the bottom, the total labor cost. So that's the benefits and the salary for the 4.8 FTE pharmacists that would be required if we were to use this calculator. So overall, a total savings of about $1.1 million, which is pretty significant. So that is the end of my information. So I'd like to hand it over to Dr. Khan and Dr. Pence.
All right. Well, whenever you invite a chief resident to speak, they're always going to talk about graduate medical education first. And I think the way that ties into our project is just how did this project come to be? So on this slide, we have kind of a schematic of what our previous longitudinal QI curriculum looked like for our PGY 1s through 3s, following a learner, manager, and leader model. As residents progress through their training, they are involved in several aspects with QI and performance improvement, including being encouraged to file safety reports, getting graded on those, reflecting on medical errors, being asked to review quality data in scheduled sessions, performing safety rounds where they go to other teams to find other safety reports to log, doing modules on the Institute of Healthcare Improvement for process improvement, attending morbidity and mortality conferences quarterly, and being involved in the QI Council. One thing that we noted when looking at it this year and what other programs do is there wasn't one definitive capstone project for the PGY 3s to complete. Everyone was encouraged to be involved in QI in some way, but that seemed to be missing. So going to the literature about this, there are 2 articles in the Journal of Graduate Medical Education that have looked at kind of instituting a mandatory QI project for a class. One of them surveyed residents after instituting it, and what they found was that residents experience feelings of separation from patient care activities when being quote unquote forced to do this, feeling isolated from interdisciplinary teams and also institutional efforts if their projects didn't necessarily align, and also developing negative attitudes towards quality improvement projects. So what these articles actually recommended is to be in this schema in the 4th box, which is essentially having the QI project be aligned with the institutional priorities and also having interdisciplinary involvement for residents to not have these feelings and actually have positive feelings towards quality improvement in the future. Just a review of the financial year 2020. I know we're in 2021 now, institutional safety goals. But one I'd like to highlight that really corresponds with our project is improving readmissions and care transitions. So we definitely have the institutional priority in mind. When we were selecting this project, we gathered ideas from stakeholders at both VCU and the VA. We narrowed it to 4 ideas that aligned both with the priorities. We offered these 4 to the residents and then had them discussed in small groups at the PGY 2 to 3 transition session, and then had them vote and selected the project by majority vote. So it's never officially a grand rounds until you get an apology for a busy slide. So this is my apology for this busy slide. I would like to introduce the C3RX readmissions reduction program. I'm sure everyone's somewhat familiar with it, but just to give an overview, it's essentially a service designed to provide safe transitions of care with regards to medications after hospital discharge. What I'd like to note is there's absolutely no cost to the patient or their insurance. C3RX is a mail order pharmacy, but the patient does not have to switch over their medications to that pharmacy. They can still fill at whatever pharmacy they like, but C3RX gives the patients the option to transition to them if they would like. The interventions that they perform are similar to everything that Dr. McIntosh had mentioned about these best practice elements. So this patient is getting home follow-up for their medication reconciliation. There are 2 visits, one within 7 days and one within 30 days of hospital discharge. Pill counts are being performed in case the patient may have had medication continued on discharge, but wasn't necessarily filled. They're ensuring that they have enough medication at home. They're performing patient education and reviewing provided medication instructions to ensure there's no confusion or discrepancies. They're also assessing whether there are potential interactions between medications that may not have been caught on the discharge medication reconciliation, and also assessing for other indications or contraindications to medications. When they do find errors, there are attempts on their part to contact either the primary care provider or the discharging provider to rectify those errors. In terms of eligibility, the eligibility criteria are fairly wide. I guess the most narrow one would be that patients would have to live within 30 miles of the VCU Health Center to get the home visits. Other requirements are, and none of these are all inclusive. Essentially, if a provider or a nurse or care coordinator is concerned about the patient's risk for readmission or adherence on discharge, they can refer them to the program. So there's no hard and fast rules besides the 30-mile rule. Other requirements that would make a patient eligible are a LACE score greater than 8, 5 or more prescriptions, which goes hand in hand with that best practice element about polypharmacy, and then 1 or more high-risk medications that's been mentioned several times. So insulin, anticoagulants, antiarrhythmics, that sort of thing. Just a brief overview of what the LACE tool is, since everyone's probably a little bit familiar but may not know everything about it. It's essentially a tool to predict 30-day readmissions and mortality. This is how the scoring system works, essentially a composite of length of stay, if it's an acute admission, comorbidities, and emergency room visits in the past 6 months. Generally, any inpatient is already going to have a score of 3. And going into what the scoring means, essentially, it's categorized into low, moderate, and high risk. The figure that you're seeing is essentially their validation model for the LACE index. On the left, you'll see the number of admissions, and on the right, you'll see the death or unplanned readmission within 30 days as a percentage. As you can see, as the LACE index score goes up, their model actually starts under predicting what the actual outcomes for the patients were. This is the most widely used tool for a couple reasons. One, the availability of the information is really easy to extract in very large data sets. And because of that, it's been integrated in several EMRs, including Epic. One thing I will point out is in the derivation cohort, this is actually a Canadian tool that was used, and greater than 95% of the patients used in the validation cohort were independent with all ADLs. So we noted, Dr. McIntosh noted previously that patients who had to rely on other family members for care or had disabilities were at higher risk, and this does not capture that. The C statistic for this model is actually not very impressive. It's only 0.684. Generally 0.7 is when you start thinking something significant, but this is kind of the tool that's most widely used. There have been several studies subsequently seeking validation, both in the United States and other countries, and the C statistic has ranged from 0.51 for heart failure to 0.72 in some American populations. That's all to say that in terms of our plan to target an intervention, this seemed to be the easiest way to extract information to do that. When looking at the data for C3RX, the most robust data we have is actually from financial year 2019. The comparison group, and I was very careful to not use terms like relative risk reduction, that sort of thing, because this wasn't any sort of propensity matching. Essentially, the comparison group are patients who could have potentially met criteria to enroll, but for whatever reason didn't. Either they refused enrollment, or they were enrolled and they didn't either make it to the first visit or the second visit within 30 days. With that being said, the difference in readmissions between the groups that were enrolled versus not were dramatic for financial year 2019. So for all services, including surgical services, as you can see here on the left, and for all these graphs, C3RX will be in red, the comparison group will be in blue. There's a 26.4% difference in 30-day readmission rate. And that's so including surgical services and all medicine services. For all medicine services combined, so it includes cardiology, oncology, digestive health, it was a 27.8 difference between the C3RX group and the comparison group. We also have cardiology and oncology here. I'm not sure what happened with this data, but there wasn't actually that many patients that were listed. There still remains a possibility of confounding with all of this, but if you correct for LACE index, whether the patient visited the ICU, which is another high risk category, what floor the patient was discharged from, and what primary diagnosis, this trend continues. So this is by LACE index category. So we've categorized it by low, moderate, and high. The group composition refers to what percentage of that group enrolled in C3RX for red versus the control group in blue comprise these groups. So as can be expected, more of the patients in the high-risk group were enrolled in C3RX versus the control group, so 46% versus 39%. But the effect on readmission rate, still, even with the higher LACE index for these patients, the readmission rate was still dramatically lower, 28% for the control group versus 19.3% for the C3RX group, so a 25% difference. And that's continued in all LACE index categories. You notice something similar with the ICU stay. So this is defined by if the patient was ever in the ICU during that hospitalization. So the C3RX group actually had more patients that had an ICU stay versus the control group, yet the readmission rates were lower in the C3RX group versus the control group anyway. If you look at what unit they were discharged from North 5, North 6, 8 West, C3, 10 East, all of them, the readmission rates are lower for the patients enrolled in C3RX. If you look at the primary diagnosis, and I admit that this data is not perfect because it's based off of ICD-10 codes, and there's a little bit of liberal evaluation where they went in terms of categories, you'll see that across the board for the most common reasons for admission, so hypertension with some sort of complication, sepsis, heart failure, COPD, and STEMI, very common causes for readmission themselves at our hospital. The C3RX group should demonstrate a dramatic difference in readmission rates versus the control group. So then our probably least favorite phrase of the year, COVID happened, and there was a dramatic effect on the C3RX program. So essentially for the entire year of 2020, the C3RX program was paused, and we have essentially no data for that entire year. Fortunately, we did have a resumption of data collection for the first quarter of the financial year 2021, so from July to October of this year. And just in comparison, there have been some, and the C3RX program had to transition to completely telehealth visits. So it is expected that there may be some changes. We also requested that their data collection methods become more granular and detailed for our analysis. So there was a reduction in just all readmission rates for those enrolled in C3RX. So now it's an 11% difference in those enrolled versus not. And this is hospital-wide compared to for financial year 2019, it was 26.4. So it's not as robust as it once was. For the medicine service, it's about the same as the year prior. So it's 30% a difference as well. And that's largely driven by a 52% difference for house staff teams versus the hospitalist teams. So as you can see, there's a huge difference here versus not that much of a difference for the hospitalist team. Unfortunately, for the financial year 2019, we didn't have that data of if the patient was on a hospital service versus not. So we can't comment on if that difference is consistent or if something else has changed. But that is encouraging in that there seems to be some error that we could potentially find to target for an intervention. And with that, I'm going to bring over Dr. Pence to go over what the house staff have done with the project.
All right, so good afternoon. So with this project, we had been given all these different options in terms of what direction we want to take with the project. And so we chose the C3RX project. And we had known that it had helped out, and we've heard about all this great data and reducing readmissions. But we want to find out a little bit more about exactly how that process worked. So two of our residents, Dorian and Jeanal, did a number of interviews with C3RX staff, and this flowchart here on the left describes that. So in a little more detail, patients are enrolled in the C3RX program. They then have a telephone call within 48 hours of leaving the hospital. With this telephone call, they're using both the discharge summary as well as a C3RX electronic record to verify which medications a patient should be on. Then this flowchart actually does represent what was going on before COVID occurred. And so that they were having an in-home visit. Now this visit is being done virtually. So then moving down the flow graph, so this goes over what happens depending on what they find with one of these medication reconciliations at the home. Going along the left portion of this flow chart is if there are no discrepancies found. But what's more interesting is when there is a discrepancy found. So they were initially categorized into 4 different categories in terms of they were missing a therapy, there's an adverse drug reaction, there's an instructional error, or the patient didn't have one of these medications at home. When these were found, the pharmacy tech would then notify the pharmacist at C3RX, who would attempt to either get in touch with the patient's primary care provider or with someone from the discharging team. If they were able to get in touch with one of those providers, they're able to make the necessary changes and update the medication list with C3RX. If they weren't, they would try to get a patient back in to see their primary care for an urgent visit. So those changes could be addressed. Then after that occurred, they'd have an additional follow-up at 30 days. And then if the patient wanted to continue pharmacy services with C3RX, they were given that opportunity. So now, with looking at some more of those errors and defining what those are a little bit more, we wanted to look into what was the type of discrepancy that was found, finding out what was most common. seeing if this had any association with a particular diagnosis at discharge, and then also looking at if medical services had variability amongst them. So this data source is from the year of 2019 going up into the spring of 2020. So as Adnan referenced, this was prior to changing the way that data was collected and prior to COVID. So you can see that these findings, instruction errors were definitely the most common, actually close to all the other categories combined. And that was then followed by medication not being found in the home. The NA intervention was a little unclear in terms of what was actually going on with that in terms of the charting that we received, and then duplicate therapies also was one of their categories. So going into some examples in terms of what was going on. So with instructions, these are just a few instructional errors that I had found and pulled out to give. So things like patients having 2 different insulins at home and not being clear which one they should resume taking at discharge. Also, a couple ones about the timing of medications in terms of like metoprolol. You can also see a patient, there was an error on the paperwork stating that a patient should start their Xarelto at day 22 as opposed to day 21. Timing of taking omeprazole with meals, taking Tylenol too frequently, and then a patient was using a daily inhaler on a PRN basis. In terms of what fell into the not found in home category, there are patients that could have numerous missing medications. They would all kind of fall into that one error category. So it wasn't just an error per medication. And these included both over-the-counter medications and prescriptions. In terms of duplicate medications, so things like patients having 2 long-acting insulins prescribed. There was another patient that had both Stiolto and Symbicort, although the Symbicort was supposed to be replaced by Stiolto, but both of those were continued at discharge. And then other high-risk things like 2 short-acting insulins being prescribed at discharge. So then we switched the data collection in July and resumed, and we're just getting some more of the granular data. 2 of our residents, Jay and Twee, did an analysis looking at did this make any changes to the frequency of errors, and was this consistent with the data that we'd seen previously? So as you can see, instructional data is still our area where we're probably lacking the most, and that we're giving correct instructions. They also define 2 different categories of med not found at home and missing therapy, which I'll define a little bit further on the next slide. Adverse drug reactions, interactions, contraindications, and the duplicate therapy also contributed to some of those as well. So in terms of defining the difference between a medication not being found in home and a missing therapy, so the med not found at home just means that the patient didn't have a medication that they were supposed to be prescribed. Again, these were both over-the-counter and prescription medications. Missing therapy refers more to when a patient was supposed to be prescribed a certain medication, but was not. So things like a bowel regimen, while on opioids, potassium supplements while on a diuretic that were previously prescribed, as well as a magnesium supplement that the patient was not told to start or stop at discharge. In terms of some examples of our adverse reactions, there are a few patients that were having either constipation or diarrhea that was attributed to a new medication that was started. And then a patient who was switched to pantoprazole at discharge, but was actually not as effective for the patients. They had to be switched back to their omeprazole. In terms of drug-drug interactions, some were concerns for sedation with numerous sedating medications or QTC prolongation. Of note, what was not really delineated in the data that we received is if these things were checked prior to the patient leaving the hospital. So that's another area where we can look further into that. In terms of examples of contraindications, there was a patient who was continued on ibuprofen after they were recently started on Eliquis. And then a duplicate therapy, there was a patient who had both omeprazole and pantoprazole prescribed. So looking more into, was there a difference by diagnosis? As you all know, heart failure, COPD, sepsis are very frequent admission diagnoses that have been seen. So this data set is from 2019 to 2020. And as you can see, sepsis had the highest frequency of errors, followed by heart failure and COPD. Interestingly, there were a decent number of pulmonary embolisms during this data set as well. And the combination of all four of these equals almost half of the discharge diagnoses. And then we broke down the data set from 2019 to spring 2020. And this had just the medicine services, house staff services, and looking to see, was there a difference in the type of error or frequency of error for any of these services? As you can see, there is some difference depending on the team, but the ordinal ranking of each of the types of errors seems to be fairly consistent, with instructions and medication not being found in the home as being the two highest for all teams. And frequently on those, the instructions were over half of the errors for each team. So in terms of our next steps with this, as with any quality improvement project, the goal is to identify an error, collect some more data about it, and then use that data to then improve that process. So some areas that we're continuing to work on is we're continuing to refine our data collection so that we're getting data back that's most helpful to help us make more changes. And some things that have stood out to us thus far are certainly improving the instructions we're giving patients at discharge, ensuring that patients have the medications that they're supposed to be prescribed and intended to leave the hospital with. And then further looking into, are there differences by services, either amongst house staff teams? Is it house staff versus non-house staff teams? We can examine more and just seeing where our best options are for intervention. So with that, I will turn it back over to Dr. McIntosh.
So I hope you get a sense of how engaged our residents were with this project. We took a lot of time to collect this data, and I thank the residents that were engaged and really committed to making this work. As Dr. Pence said, the next step is going to figure out what the intervention will be and continue to study this data. I do want to thank some of the folks that helped us to collect this data set. So Cynthia Matthews and Performance Improvement and Coordinated Care and Post-Acute Services. Jenna Cesarnota was the data scientist, and Irene Zolatoro with care coordination. And of course, Derek Leiner, who's the Associate Director for Quality and Patient Safety for our residency program. And of course, Dr. Khan and Dr. Pence, who helped to drive a lot of this work. One question that was seen in the chat was whether the telehealth option was, or the restriction in terms of mileage was relaxed for patients because of COVID.
No, they kept it the same because there was tentatively plans to transition back. That may have been a little early to do, but currently the restriction is still in place.
Thank you, Dr. Khan. So with that, I'm going to stop. And I know that we might not have much time in terms of questions, but please, if there's any thoughts or suggestions for us in the future, we'd be happy to hear any thoughts or any suggestions for this project or future projects. And I thank you for your time.
I just want to say thank you again. This is a wonderful data-driven grand rounds. I really appreciate all the work that you did, and I really appreciate the engagement of our trainees. Fantastic job, you all. Thank you very much.
Thank you all. think that's it. So have a good afternoon, everyone.